This recorded lecture will be going over Chapter 20, Care of Patients with Coronary Artery Disease and Cardiac Surgery, in the MedSurg textbook. Coronary artery disease is a progressive disease leading to narrowing or occlusion of the coronary arteries. The coronary arteries are responsible for supplying oxygen and nutrition to the myocardium. As the coronary vessel narrows, the patient can experience symptoms of ischemia. This includes chest tightness and angina. When a sudden obstruction to blood flow through one or more of the major coronary arteries occurs, it will cut off oxygen and nutrients to the cardiac cells, leading to a myocardial infarction, or an MI. With rapid intervention, the amount of infarcted tissue can be limited. A major factor in the development of CAD is atherosclerosis, in which plaque containing cholesterol and lipids is laid down within walls of the arteries as fatty streaks. Coronary arteries are smaller, and narrowing here produces symptoms sooner than in the larger vessels. Atherosclerosis is one form of arteriosclerosis. Factors such as age, being older than 40 years old, gender, and race can contribute to the disease. However, these characteristics cannot be modified. The process of atherosclerosis begins during late childhood, when streaks or islands of fatty material are laid down on the inner walls of the arteries. Low-density lipoprotein, or LDL cholesterol, is the major contributing factor to the formation of this fatty material. The plaque area can protrude into the artery, decreasing the vessel size. Over time, this plaque can begin to calcify, causing rigidity of the vessel wall. The further narrowing of the coronary arteries will lead to coronary insufficiency. This is a decreased or insufficient blood flow. There is a proven link between hyperlipidemia or high levels of LDL and triglycerides and atherosclerosis. As CAD progresses, the coronary vessels will become narrower, decreasing the blood supply to the myocardium. This will result in angina pectoris, or chest pain. When plaque areas rupture, the rough edges can cause platelet clumping and clotting, known as thrombosis. The lack of blood supply will lead to ischemia and eventually necrosis of the myocardium. If significant loss of muscle tissue occurs, the heart muscle will be unable to pump blood effectively and cardiac output is reduced. On page 463, you can see the picture on this slide demonstrating the progression of atherosclerosis. Take a look also at page 462, box 20.1, Signs and Symptoms of Coronary Artery Disease, including chest discomfort. It could feel like tightness, aching, or burning. Chest pain, possibly radiating to the arm, jaw, or back. Shortness of breath, palpitations or tachycardia, nausea and vomiting, fatigue, particularly in women, and weakness or an inability to complete typical ADLs. Signs and symptoms of CAD are related to the lack of oxygen supply to the myocardium and the inability of the heart to pump blood effectively to oxygenate the tissues and cells. Classic signs of angina in men can include chest discomfort that may be described as a pressure heaviness or squeezing. The pain will be located in the mid-chest area and can radiate to the neck, jaw, or arm. Women might say that they feel short of breath or nauseated or just have vomiting or abdominal pain. The diagnosis of CAD can be accomplished through tests such as an EKG, echocardiogram, cardiac stress test, cardiac angiography, CT angiogram, or MRI angiogram. Lab testing for risk factors would include a lipid panel, blood glucose, and a hemoglobin A1C. A low-fat diet, weight control, and exercise are prescribed to lower cholesterol and total lipids. If elevated cholesterol and triglyceride levels cannot be lowered by a low-fat diet and exercise, lipid-lowering drugs will be prescribed. Patients should be encouraged to adopt a healthy lifestyle, including exercise and a diet that is low in saturated fats. A cardiac rehabilitation program referral can be very helpful. This program will help the patient choose an exercise regimen that they will be able to manage over a long period of time. If the patient is taking a statin drug to lower their blood cholesterol, remind them that they need to have their blood drawn periodically to determine whether the drug is effective and monitor for any serious side effects. On page 464, see the purple box of clinical cues. Because statins can injure muscle tissue and are toxic to the liver in some patients, blood should be drawn for levels of creatine kinase and for liver enzymes. Elevated liver enzymes can indicate toxic damage to the liver. Patients should be told to report any unexplained muscle tenderness or pain that persists for more than a few days. When a statin drug is started, baseline blood values will be obtained before therapy. Lab tests for liver enzymes are recommended at the start of therapy and only whenever clinically indicated after that. Grapefruit juice should not be consumed when taking a statin drug. It will interfere with the metabolism of the drug, which can lead to increased serum levels and increase the risk of toxicity. The ischemia, or inadequate blood and oxygen supply to the heart, will cause pain. Any activity that increases the heart's workload will increase its need for oxygen. When the narrowed coronary arteries cannot deliver the adequate amount of blood to meet normal needs, the patient will experience an angina attack. Anginal pain or discomfort can vary in individuals, but in most cases it will be described as a dull pressure or an ache, typically under the sternum, or a pain that radiates to the neck or jaw. Angina sensation is seldom sharp or stabbing. In women, there might not be any chest pain, instead just a tenderness to touch or a burning or tingling sensation. Stable coronary artery disease, or SCAD, formerly known as stable angina, can be induced by stressors, including exercise or emotion. This can also occur spontaneously. Coronary artery disease is an ongoing process unless it is interrupted by changes in lifestyle and medications. Any patient exhibiting angina symptoms should be evaluated by a healthcare provider. A medical diagnosis will be established based on the history, clinical signs and symptoms, and diagnostic testing. If non-invasive testing is positive, cardiac catheterization with coronary angiography may be performed. An EKG is a standard diagnostic procedure. The treatment of SCAD is mostly symptomatic, with emphasis on eliminating those factors that are known to precipitate an attack for that individual patient. Nitroglycerin, nitrates, calcium antagonists, and beta blockers will be used in combination with other drugs to lower cholesterol and prevent any platelet aggregation. Antiplatelet medications such as aspirin or Plavix can help prevent clotting and may help prevent a thrombus that could lead to an MI. Nursing management includes collecting data that will assist in determining the type of angina that the patient is experiencing. If ischemia is prolonged and not quickly reversed, acute coronary syndrome will occur. Acute coronary syndrome is an umbrella term. It includes unstable angina, NSTEMI, STEMI. All patients with heart disease should be taught the signs of MI and be advised that the best survival rate will be directly related to obtaining medical attention as quickly as possible. Women will be more likely to experience heart attacks after reaching menopause. However, poor dietary habits, a sedentary lifestyle, and increased levels of stress will contribute to the development of cardiovascular disease earlier in life for an increasing number of women. An MI is typically caused by thrombosis, resulting from a ruptured atherosclerotic plaque. An infarction is an area of necrosis in tissue caused by an obstruction to the flow of blood that will go on for a prolonged period of time. In an MI, there is an area of necrosis in the heart muscle. That portion of the heart muscle will not contract normally and will not be able to help pump blood out of the heart. The prognosis for patients experiencing an acute MI will depend on the location and the amount of heart tissue that has been damaged. As the coronary vessels narrow over time, small blood vessels will be formed that can supply oxygen to the myocardium. This is known as collateral circulation. A patient with a well-established collateral circulation can experience a milder heart attack with fewer complications. Classically, during an MI, there is sudden, severe pain in the chest, typically described as tightness, pressure, squeezing, or crushing. It will not be relieved by nitrates or rest. The patient will also show symptoms of dyspnea, nausea with or without vomiting, wheezing, and ashen, clammy, cool skin. Signs of shock would include pallor, profuse sweating, and anxiety. In older adults, the attack can manifest as fatigue, syncope, or weakness. Women will often complain of recent episodes of extreme fatigue with an inability to complete ADLs without prolonged rest periods. These episodes can be accompanied by chest pressure, followed by an eventual return to a full energy state. Women will tend to present with atypical symptoms, including sharp pain, fatigue, and weakness during an MI. Although these symptoms are present in an acute MI, they may not always be severe, and in some cases, patients will describe their pain as mild. It is paramount for the patient to seek quick medical attention whenever experiencing any onset of new chest pain. The window of time to prevent any significant myocardial damage is very narrow, about 6 hours, and the sooner medical treatment is started for an MI, the greater the chance of saving myocardium and preserving life. An EKG will be performed promptly when the patient is having any symptoms that could indicate ACS. STEMI or NSTEMI should be ruled out immediately based on the EKG. Changes will occur in the QRS complex, ST segment, and the T wave whenever ischemia or damaged tissue is occurring. A chest X-ray will rule out any other possible causes of the symptoms, such as a thoracic aortic aneurysm. Troponin levels are the preferred biomarker for diagnosis. A serum troponin T and troponin I are elevated within a few hours of the MI. Troponin can only be found in cardiac tissue. The most significant laboratory finding for the diagnosis of an MI is an elevated troponin level, especially if it is accompanied by an elevated CK-MB. Cardiac catheterization with angiography may be performed soon after the patient is admitted to the ER if the MI is the probable diagnosis. Outside of the hospital, when chest pain occurs, the patient should chew and swallow an aspirin whenever the symptoms of MI happen. It is recommended that a 12-lead EKG should be done in the field and then transmitted to the receiving hospital. MONA, or morphine, oxygen, nitrates, and aspirin regimen should be initiated. Sublingual nitroglycerin should be given unless it is contraindicated. Drugs can be administered IV to control pain in a patient with acute MI, including morphine sulfate or hydromorphone. Morphine is the drug of choice because it is a vasodilator. Pain medication given IV will have a shorter duration, and doses may need to be repeated more frequently to keep the patient comfortable. A bolus of heparin will be given, and a heparin drip started to prevent the clot from enlarging. This will only be given after the initial chest X-ray to rule out any aneurysm or hemorrhage. Close assessment of respiration is essential because the drugs for pain can depress respiration at a time when the heart's oxygen demand will be increased. Pulse oximetry will be instituted quickly in order to measure oxygen saturation. In many communities, facilities with cardiac catheterization compatibilities may be designated as STEMI receiving hospitals. Protocols are in place to fast-track the diagnosis and mobilization of intervention teams to quickly treat a patient experiencing an MI. Thrombolytic therapy is started preferably within 6 hours, but it can be given up to 12 hours after the onset of symptoms in order to prevent necrosis of the myocardium. This is indicated whenever the EKG shows ST segment elevation. To meet core measures, standard thrombolytics should be given within 30 minutes of arrival to the hospital. Agents used intravenously to dissolve the clot would include alteplase, tenecteplase, and retaplase. These drugs are contraindicated in patients with severe uncontrolled hypertension or a recent history of hemorrhagic stroke, GI bleed, intracranial or intraspinal surgery within the past 2 months, a brain tumor, AV malformation, or aneurysm. Whenever a patient is not a candidate for thrombolytic therapy, heparin and low-dose aspirin can be administered to prevent further thrombosis. In the acute phase of MI, nursing care will be directed towards preparing the patient for possible PCI or thrombolytic therapy, relieving patient pain, administering ordered medical therapy and, of course, observing for any side effects, monitoring for any complications of MI, including dysrhythmia, heart failure, pulmonary edema, pericarditis, cardiogenic shock, or cardiac arrest, and maintaining patent IV access at all times. In the recovery phase of MI, nursing care is directed towards the following: decreasing anxiety and stress for the patient. Explain the function of all equipment and tests in very simple terms. Monitoring physical status by performing a thorough cardiovascular assessment every 4 to 8 hours and monitoring vital signs every 2 to 4 hours. Recording daily weight and comparing with the previous weight. Intake and output should be strictly recorded. Promoting rest, monitoring tolerance of activities of daily living and ambulation, and assisting with any rehabilitation activities. Patients with damage to the myocardium are admitted to the CCU or telemetry, where they will initially be kept on bed rest. Physical activity will be gradually increased according to the patient's individual condition and their response to activity. Vital signs and SpO2 should be continuously monitored by electronic means and typically are assessed every 15 minutes to 2 hours. Continuous ECG monitoring will be essential to provide an accurate evaluation of the status of the heart. A healthy heart diet will be ordered when the patient's vital signs have stabilized. A stool softener will be given to decrease the risk of bradycardia, which can be caused by straining due to having a bowel movement. Various IV drugs can be used to regulate blood pressure or control a dysrhythmia. While in the CCU, if hemodynamic instability is present, a pulmonary artery flow-directed catheter or Swan's-Ganz type catheter can be inserted to monitor central venous pressure, pulmonary artery pressure, pulmonary capillary wedge pressure, and cardiac output. This will give a better picture of the injured heart's ability to pump. If the left ventricle is badly damaged, cardiogenic shock can occur. Signs and symptoms include those that would accompany decreased cardiac output, such as decreased BP, confusion, restlessness, diaphoresis, rapid and thready pulse, increased respiratory rate, cold and clammy skin, and a diminishing urine output to less than 20 mL per hour. An intra-aortic balloon pump can be used to ease the heart's workload while it begins to heal. Only RNs who are certified in the care of patients using an intra-aortic balloon pump would be assigned to care for those patients. While the patient is on the telemetry unit, physical activities will be gradually increased according to the patient's ability to tolerate exercise. This will be evidenced by a stable heart rate, blood pressure, and respiratory rate. Patients with a STEMI who arrive for treatment before significant left ventricular damage has occurred might be sent to telemetry after their PCI and may be hospitalized for only 24 to 48 hours. The patient and the family might need help and support as they work to make necessary adjustments after this occurs. Many hospitals can offer an outpatient cardiac rehabilitation program to help the patient make lifestyle changes and further reduce any future risk of cardiac problems. This program can provide counseling on dietary changes for a heart-healthy diet, stress reduction techniques, reduction of risk factors such as avoiding tobacco use, controlling hypertension and diabetes, and a supervised exercise program with continuous EKG monitoring for 4 to 6 weeks. A support group consisting of other individuals who have the same condition or who have had a similar surgery can be helpful. One area of major concern is sexuality. The patient may be fearful of resuming intercourse, thinking that it could cause a heart attack. The partner will often have these fears as well. Both partners will need reassurance that resumption of normal sexual activities will be possible. The patient should be told that the workload of intercourse with a known partner is equivalent to climbing a flight of stairs. If a flight of stairs can be climbed without much change in heart rate, respirations, or blood pressure, then intercourse should not cause any harm. Patients should be taught to plan their sexual activity for times when they are well rested and to avoid an environment that is too hot or too cold. Levels of physical activity will be designated through metabolic equivalent units, or MET. 1 MET is the equivalent of oxygen needed by the body at rest. The patient's rehabilitation program will slowly progress in a stepwise order to higher energy expenditures over a period of months. Rehabilitation involves three major aspects: a program of increasing activity based on the individual's progress and needs, instruction of the patient and family about the nature of the illness, including a rationale for every aspect of management, and assistance to the patient and family as they work towards the goal of accepting the limitations imposed on the changes and lifestyle that may be required. The goal is to have the patient and family continue with the heart healthy living even after their program has ended. If only a few areas of stenosis have been identified, a PCI may be performed. The patient could possibly have a PTCA rather than a CABG to improve blood flow. This is a non-surgical intervention technique that can open blocked coronary arteries. To maintain patency of a vessel, a coronary stent will typically be placed. The stent can be made of stainless steel and act as a brace for the artery wall. A bare metal or drug-eluting stent can also be placed in the artery to help maintain the patency of the vessels. They will have a coating of a drug that will be released slowly over several weeks after placement. When a stent is placed, the patient has to take antiplatelet agents such as aspirin or Plavix for up to a year after placement. The patient may be up and about within 2 to 4 hours when an arterial closure device is used to seal the procedure site. Distal pulses on the affected leg should be assessed frequently, and the groin area should be assessed for the presence of hemorrhage or hematoma. Renal function should be monitored due to the potential adverse effects of contrast dyes used during the procedure. CABG might be indicated if there is multivessel disease or a critical lesion that puts a large portion of the myocardium at risk. Other procedures to remedy clots and plaque would include laser angioplasty, thrombectomy, and arthrectomy. The nurse should encourage fluid intake post-PCI with angiography. This will be to assist the renal function and flush the dye out of the kidneys. For patients who are critically ill and not candidates for PTCA or CABG, a transmyocardial laser revascularization technique is an option. This is known as TMR. This procedure is done with general anesthesia without the use of cardiopulmonary bypass, and the heart can be approached through a small thoracotomy incision. The term open heart surgery refers to the use of a heart-lung machine during the procedure. This machine will function as an artificial heart and lung. Open heart surgery technically means that the chest is opened, the heart is stopped, and blood is routed through the heart-lung machine. Congenital heart defects, valve replacements, bypass of clogged coronary arteries, and heart transplant would be conditions that require surgical repair. A CABG surgery will be performed when ischemia cannot be controlled medically or to prevent greater occlusion and consequent MI. The CABG surgery will bypass the artery that is blocked, replacing it with sections of a vein or artery that will be taken from another part of the patient's body. The mammary artery or sections of the saphenous vein or radial artery are typically grafted. Use of robotics assistance is becoming more common in all aspects of surgery. The advances in technology are being applied to coronary bypass and intracardiac procedures. Many patients who had a coronary artery bypass in the past 10 years are now returning for second operations because the grafted arteries or venous bypass grafts have now become occluded. Due to this, a greater emphasis is now being placed on the need for adherence to lifestyle changes in order to prevent a second operation. Heart transplants can be performed for selected patients with a history of hospitalizations for heart failure, those requiring a left ventricular assist device, those needing increasing types and doses of medications or documentation of a decreased oxygen supply to the body, measured by the VO2. This is the amount of oxygen consumption by tissues in the body. Patients with good renal function and who are psychologically stable. There is some flexibility with age requirement. Very few donor hearts are available, and the waiting lists are long. In addition to meeting transplant criteria, patients are limited by geography. A heart can be out of the donor body for only 4 to 6 hours if it is to be successfully transplanted into a recipient. The benefits of heart transplant are considerable, with an average 1-year survival rate of about 85 to 90%, a 3-year survival rate of about 75%, and a 5-year survival rate of 60%. Transplant patients must adhere to strict dietary and exercise regimens to prevent the new heart from becoming affected with problems that led to their original heart failure. Patients awaiting a heart transplant will be placed on a national waiting list. Preoperative care. The teaching plan should include expectations during the preoperative and postoperative periods. If the surgery was done emergent, of course the teaching must be done after the procedure. Specific interventions regarding what medications to take and which ones to stop must be included in the preoperative instructions. During the early postoperative period, the patient will remain in a CCU where specialized cardiac monitoring equipment can be used and highly skilled personnel will be in constant attendance. Cardiac rate and rhythm will be monitored closely. For patients who had an open heart procedure, chest tubes for drainage and proper re-expansion of the lungs will be in place for at least 24 hours. Chest tubes are typically removed before the patient is moved out of the CCU. Usually a multi-lumen central line will be in place for medication delivery and fluid maintenance, as well as an arterial line and pulmonary artery line to monitor hemodynamics. Urine output will be initially monitored hourly for the first 8 hours and thereafter every 2 hours to detect any signs of decreased perfusion to the kidneys. After the first 12 to 24 hours, the surgeon will assess the patient's condition and then decide whether they should be transferred to a step-down unit. Lung sounds and oxygenation are priority assessments. Daily weight must be monitored to assess fluid balance. The physiologic symptoms that can persist into the home recovery period include fatigue and weakness, incisional discomfort, edema in the donor leg, dysrhythmias, loss of appetite, and unusual physical sensations. Depression for weeks to months can occur after heart surgery. It is important that bypass surgery patients and their families realize that bypass surgery is not a cure for CAD. Skin cancer will be the most common malignancy after organ transplant. The goals of home care are to monitor the patient's condition and to prevent any complications, including life-threatening dysrhythmias, MI, and congestive heart failure.